Hi, I'm Dr. Randall Thomas from Orthopedic Foot Ankle Center here in Columbus, Ohio, talking to you about a very common and painful foot condition called plantar fasciitis, also known as heel spur syndrome. So the plantar fascia is a ligament on the bottom of the foot. This is soft tissue that connects bone to bone. It runs from the heel to underneath the toes, essentially. And it can become inflamed in multiple areas, kind of right at the heel, mid-substance in the arch, or further out towards the toes. Usually a fairly chronic condition where the ligament is inflamed over time and become more painful and difficult to walk. This is very commonly treated with patients suffering from this throughout the country every day. A lot of people try inserts, over-the-counter treatment, stretching, and usually it's gone on for several months before they see their doctor. So this is a condition of inflammation, could lead to tearing or could become from trauma to the ligament on the bottom of the foot, can or cannot be associated with a heel spur. So kind of a misnomer, the heel spur syndrome. These heel spurs can occur, and they do recur as a result of the ligament being tight and pulling on them. One of the common things people come in for is to say, hey, can we cut out this heel spur on the bottom of my foot? Well, a lot of times if you just cut out the heel spur, you would not get any better because the ligament's the problem. The ligament pulling tightly on the bone is causing the heel spur to grow. The classic symptom of plantar fasciitis is pain when you first wake up in the morning. Patients feel very hobbled in the morning. They're having difficulty putting any weight on the heel. They're tending to walk on their toes. And as they go along their day throughout the morning, this tends to get better. Most people say within 5 to 10 minutes, their pain starts to subside. And the other classic finding is anytime you're at rest and then get up, this occurs. So not just in the morning. You could be sitting at a desk working, eating lunch or dinner, off your feet for a while, go to get up, and you have a lot of pain at the heel. A sharp, direct pain, almost like a tearing pain at the heel, and people have difficulty walking. Other symptoms can be nerve-related, as this can get large and push on a nerve, or we can have a nerve causing the pain in itself. We can have bruising or edema, we can have swelling and inflammation, some numbness that could occur, as I said. Typically, though, it's pain when you first wake up, pain when you're barefoot. So the causes of this are a chronic inflammation that your body's ignoring. Basically, the ligament is inflamed beyond the normal amount at the bottom of the heel, and the body's not going down and trying to fight this. A lot of the treatments are actually designed to try to create an inflammatory response, essentially cause an acute injury and get your body to heal it. So the causes are typically related to tightness in the calf muscle. We know the tighter you are in the calf, the more pain you'll have on the bottom of the heel directly. Also, the more weight bearing you put through the bottom of the foot if you don't have mobility at the ankle. The other causes can be edema in the bone, swelling in the bone. You can have things like stress fractures. The heel spurs can lead to more inflammation at times of the ligament. Could be from an injury in the past. Could be from poor fitting shoes, overuse activities, body habitus such as weight or the mechanics of how you walk. Some gait changes can lead to this. Not uncommon to see this after patients are immobilized for some time. For example, they had another surgery that kept them down somewhere else in their body. They go to get up and be active, and this ligament on the bottom is tightened and inflamed, and it takes a while to loosen back up. Typically diagnosed by physical exam, there's some specific characteristics that will show with plantar fasciitis, or even having heel spurs as well. One of the things we want to rule out is a nerve entrapment, be that at the foot or further up in the leg or back. Typically it's done by the physical exam and x-ray. X-rays, you can usually see a spur, may even see inflammation of the ligament on x-ray. We usually don't see soft tissue, but it's inflamed enough we can change the density and see this sometimes. Very commonly diagnosed or confirmed with MRI or ultrasound. Sometimes ultrasound is used in our office just to measure the thickness of the fascia, and there are certain parameters that show that it's plantar fasciitis or an inflamed fascia or not. To find out more detail, the ultrasound or the MRI could tell us to what extent, what location, is there any associated tearing or bone edema, or any type of bruising to the bone as well. Physical therapy or home exercise programs, topical anti-inflammatories or creams, compound creams, anti-inflammatories by mouth or steroids by mouth. We don't take some of the medications lightly. If we can treat it locally, we do instead of a systemic medication. This sometimes leads to patients having injections of steroid. Now, there are limitations in how many steroid injections you can have, because it can lead to weakness and tearing of the ligament. It can lead to breakdown of the bone or other problems. But in a certain setting, with 1 or 2 injections, sometimes we can get this to resolve. I myself have had plantar fasciitis, and I fought it for about 5 months. I had 1 injection, it went away a couple days later and did not come back. So I certainly have empathy for this condition. There are a lot of modifications to shoes and conservative treatment we can do. If those don't work, then we can go to the next step of shockwave therapy, very similar to what's used for breaking up kidney stones, but used on the foot. It's a pulse therapy to cause this inflammation and breakdown of the thickness of the ligament inflammation. There's also a procedure called 10X, which is an ultrasound procedure done by us or one of the sports medicine doctors that can have the ligament shrink down through an ultrasound and saline irrigation type of procedure. If those conservative measures don't work, also, but not always including, platelet-rich plasma injections or stem cell amniotic membrane allograft injections, then we undergo surgical intervention. From a surgical standpoint, there are multiple ways, from minimal invasive to full open procedures. I will tell you, we try to avoid the open procedures where the incision is on the side of the heel, because that is fraught with complications of dehiscence or wounds, infection, and chronic pain. We want to make sure the patients are going to be compliant being off of it. So I would say most commonly, we do an incision on the bottom of the foot, just in front of where the ligament goes into the heel bone. This is a non-weight-bearing part of the foot, so it doesn't hurt when they walk. We have to have the patients off that for a little bit of time so they don't get a thick scar. We don't want to trade pain with an inflammation for scar pain chronically. There's also something called TOPAZ, or radiofrequency coablation. That's using a little wand device and activating this into the fascia to get it to shrink. This is done through poke holes without stitches. Patients do very well with it. So I'd say most commonly, it's an open procedure directly on the bottom, again, not on the side, or it's a percutaneous or poke hole procedure. There are some other minimal invasive techniques with guided imaging, like fluoroscopy imaging and needles or blades. If we do an open procedure, we sometimes do have to take out the spur if we think that's a culprit or part of the pain. We want to be very cautious not to decrease the fat pad on the bottom of the foot, because then you could have pain anyway by hitting the bone more. Depending on what surgery we use, the recovery process can vary. If it's one of these less invasive procedures, like these poke hole procedures, it could be 1 to 3 weeks off the foot in a boot. If we do an open procedure, it could be up to 6 weeks of non-weight bearing, followed by getting in a boot at week 6. Regardless, by week 6, we're in physical therapy or doing exercise on our own. We'll give you a packet to do or send you to physical therapy itself. And we're starting to advance to shoes. Sometimes with orthotics, we think of the orthotics kind of like a retainer to braces idea. You fix the bottom, then you wear the custom orthotics to hold the position long term. And that's not only to prevent recurrence, but to speed up the timing of healing. Swelling is something that can take months to go away, but usually by 6 weeks, people are back to doing their normal activities. Higher impact activities, sports, running, jumping, around 12 weeks post-operative. And again, this could vary, and your individual surgeon could discuss that with you depending on whether it's a more minimal invasive or an open technique. The risk of surgery can vary. Certainly there's risk of anesthesia. There can be risk of nerve blocks related to that. We're not putting in implantable hardware. There are risks if we take out the spur of recurrence, although very low. Risk of fracturing the bone if it's become incompetent or stressed. With the ligament itself, it's very rare to see recurrence. Some of the older ways of doing this, where the ligament was simply cut, we would see that it would re-adhere itself and start to inflame and scar and have more pain and recur. Now we have better ways of addressing this. If you're doing the less invasive procedure, it's a less recovery, but a potential for more recurrence. If we do more of the open traditional procedures, there's more risk of infection. If we do more of a newer procedure on the bottom of the foot open, there's less risk of recurrence and infection. Yeah, it's tough to diagnose a patient with plantar fasciitis just because you feel for them. It can be a chronic, lifelong condition. You hear a lot of patients say that they fight with this off and on throughout their lives for decades. Our goal is to kind of get rid of it as quickly as we can. If it goes beyond 6 months, we're going to intervene with more aggressive treatment and try to get it to go away long term. We want to make sure we're evaluating the whole foot and lower leg. Sometimes this is being caused by tightness in the calf or other tendon imbalance or other issues with alignment of the bones and joints. So we don't want to miss that in our treatment paradigm. If we can get that aligned and address, such as lengthening a tendon in the back of the leg or dealing with a hind foot or back of the foot deformity, this can help prevent recurrence. One of the concerns is that you would have this waxing and waning pain off and on. So as long as we're fairly aggressive with it and we have follow through, the goal is to get it to go away and not have it recur. And if it does recur in a much milder form, where we could just wear inserts or do a little bit of stretching to prevent it. A lot of times it has to do with tightness in muscles and tendons. So we always tell the patients if they can continue to stretch long term, hopefully they can prevent that recurrence. But with the operative intervention, people do very well, and we do not expect it to recur once they get past the initial healing phase. Yeah, commonly treated by other providers. I see a lot of patients say they start treatment with their primary care, and many of our primary care in Central Ohio are great. They're doing the whole workup, physical therapy, stretching, topicals, anti-inflammatories. They even get the imaging and MRI and then send them to us for surgical intervention. They work with the patient for 6 months, they're not getting better, and so they see us. Sometimes we can employ some other conservative measures, sometimes we go into surgery at that point. The other treating providers are physical therapy. We see a lot of chiropractors. We even see neurologists if they think it's a nerve entrapment or if it's pushing on a nerve. So a host of providers can start the treatment. I would say that we are the most versed in kind of the end stage treatment, meaning we see the patients when they're at their worst and usually going to surgery to fix it. And we have good outcomes from it, but the sooner we can see someone, the better. So if they could come to their foot and ankle surgeon and provider when the onset of symptoms is early, say within the first month, we sometimes save a lot of that time. We don't jump to surgery in that case. We just hit it with a global approach, kind of multimodal approach to treat this, not only from the cause with the symptoms, and a lot of times it doesn't progress to where we need surgery. We're happy to see these patients, and it's really good because we can see the outcomes that we're going to get, very reproducible. We know people are going to be happy, but the sooner the better.